spermatozoa. So we will see what are the things that we should do when the patient comes to us with Azoospermia. What do we do if he is of sperm of low volume or normal volume? Failure to ejaculate, I think, will be covered by Mr. Murali. And then what are the management options? And then I'll talk about a bit on when do you do biopsy, what's the role of reproductive and hormonal treatment. Is there any role? So what are the causes of azoospermia? We can divide into three major ones: before the testis, due to the testis, or post-testicular. The commonest cause of pre-testicular is by far the hypogonadal, hypogonadism. Something wrong with the HPO axis leading to decreased information of spermatogenesis. Testicular causes usually is what we call non-obstetric cause. That means the kedah itself failed to produce any spermatozoa. Either be it production is low, spermatogenesis is reduced, or there is production of sperm but it somehow failed to mature into normal spermatozoa. And post-testicular are the obstructive or ejective dysfunction, covered more by urologists later. So either the problem is here or here or here. If you take testis and split it into two, under anesthesia of course, you find that there's a lot of what we call seminiferous tubules. This is where the spermatozoa are formed. Then it goes up to be collected at the epididymis. I usually say to patient, ni kepala dia. Oh, doktor, dah ada kepala lagi? Yes, ada kepala lagi satu. Then after that it goes up to the ductus vas deferens, and then it is then comes out during ejaculation. So sometimes people think that patient thinks that air mani comes from here. No, the benih comes from there. So how is it formed? You cut it some more and look at the microscope. From primordial germ cell, it divides, mitotic division, into primary spermatids, and then it goes to first mitotic division into secondary spermatids, and this where is mature. From spermatids it goes to spermatozoa. This is quite interesting because people have claimed that they can get pregnancy by injecting spermatids during ICSI, but I'm a bit skeptical of that. But there are studies to show that they have got pregnancies. Unfortunately, those pregnancies are all miscarriage. There's a condition called Toady cell syndrome, where only Toady cells, which is the cells that nurture the immature sperm, are lined by the seminiferous tubules. Okay? So they don't achieve form or mature spermatozoa. It occurs in patients between 20 to 40 years of age, and usually they can be associated with Klinefelter syndrome. The cause is still unknown. Could be genetic, chemical, toxin, history of radiation or viral infection. How you diagnose it? You have to do a testicular biopsy, open it up and look under the microscope, and you find there's a lot of only Toady cells here. There's no spermatozoa. There's another condition called maturation arrest in testicular problem, where it is diagnosed on histology as interruption of spermatogenesis before the final stage, without impairment of the Toady cells or the Leydig cells. So somehow it has arrest and tidak jadi mature spermatozoa. It is irreversible and it's causes of severe infertility or absolute infertility. This kind of patient will come to you with a sperm results of azoospermia. The sperm, the volume may be normal, 1.5 ml or above, but you look under the microscope, there is no tadpoles, swimming around. Sperm production deteriorates, and ultimately the patient has azoospermia. So when the patient comes to you with azoospermia, in medical school teaches us to first get the history. How long have they been trying to get pregnant, a couple, whether he has previous children before from a different partner, is there any problem of libido, and how's the sexual activity, how often do you do sexual intercourse with your wife. You look at the patient as a whole for any problems like diabetes or respiratory issues. Why respiratory issues here? It's not very common here in Malaysia, in our population, but cystic fibrosis is commoner in Caucasian. Is there any history of genital urinary tract infection like chlamydia or gonorrhea, which is more common nowadays? Any history of operation to his testis, or any history of hernia operation, because that do affect. Any history of medication, for instance, he's taking steroids, hormones, the abang sado, right? Dia nak increase dia punya ni. What patient ask me, what about proteins? Proteins are quite okay, but sometimes some proteins they add something inside that content, so you better be careful. Some patients who have gone radiation chemotherapy may affect or will definitely affect their testicular function. What type of work that he does? Those exposed to pesticides, excessive heat, those who work in the minefield or dalam gua, or those who like to wear very tight pants, or those who like to sit on very hot saunas and things like that may affect. Any recreational drugs like marijuana and all that also can affect your sperm. So if you have a patient with azoospermia, don't label him straight saying that you have a problem. What do we do? Like I mentioned earlier, you must have at least 2 semen analysis. So repeat one more, ideally 72 days later lah. But then sometimes they can't wait, you can repeat again in a few weeks time. If they are on any form of gonadotoxic agents, please switch it off, take them off, and then do a sperm analysis again 3 to 6 months later. Not right away. Like I said, it will take 90 days, 72 to 90 days to form new sperm batch. If they have history of serious illness or injury to the area, or on radiotherapy or on infection, had history of infection, repeat again after 3 months that the patient have cleared from the illness. Okay, semen analysis, this is what we look for or look at when we ask the lab to do semen analysis. Volume, this is the latest WHO classification, 2010. Last time, before that, WHO gave another classification in 1999 where everything was higher than that. So that means to say that, a year, every 10 or 15 years when the WHO do a new classification, we find that the number of sperm, especially sperm concentration, what is normal then is no longer normal now. Back in the 40s, it used to be 40 million. And then in 1999, WHO brought it down to 20 million. And then in 2010, it bring down to 15 million. Because they found out 15 million per mil ni cukup untuk mengandungkan seorang wanita yang subur lah. So I takut lama in 2025 it bring down to 5 million. Tak tahu lah. Tapi I don't think 5 million you can mengandungkan somebody kan. Used to show that orang laki-laki ni bukan saja kurang, dah kurang kan. A lot of sajat nowadays. Anyway, morphology also has reduced. Used to be 20%. Now they follow the strict Kruger's criteria, which they take about 4%. More 4% ni, you can't look under normal microscope of power of 20 or even 100 there is a test that should be done to look at the properly to look at the morphology. That's why we take it at 4%. But we in the who does IVF, we don't take too much of all this. We just these three things yang penting bagi kami, motility, the count, and the morphology. So look at the volume area. Now, if the patient have azoospermia with reduced volume tadi 1.5 kan? Okay, kalau lesser than 1.5, you must make sure that kadang-kadang dia bagi botol kan, botol tu sikit je. Kenapa sikit ni? First you must find out kenapa sikit. Yeah, because you have to rule out things like artifact. Sometimes the guy, due to excitement or whatever reason, miss the bottle, so it's all on the floor. It happens, you know. And then sometimes you don't give a big container, a big mouth container, small test tube. Kesian lah kawan tu kan, macam mana direct. So please give a nice, big, not too sharp, because some of the yang yellow tu agak tajam. Because I've also come across where suddenly we find RBCs inside there. Rupanya melecet, tak tahu kita kena mulut tu. Or some difficulty in producing sperm. They must at least have 3 days of abstinence. I used to tell my patient 3 hari puasa. Memang dia puasa tak makan, tapi dia keluar air mandi dia pagi tadi. So I get okay, 3 hari jangan bersama isteri. Memang dia duduk rumah kawan, tapi keluar juga air mandi tiap pagi. So now I just say, jangan keluarkan air mani you dengan apa cara sekalipun untuk 3 hari. Maka dia simpanlah untuk 3 minggu. 3 minggu pula, the problem is you have a lot of volume, but all your sperms are lazy. They're not moving. They're not moving. So 3 days, 3 to 7 days is the ideal. So you must make sure that it's really truly or artifact. And then the sperm semen is produced mainly by the seminal vesicles and to a lesser extent prostate, 90%. The seminal vesicles abnormality or obstruction can cause a decrease in the volume of the semen. So when you have decrease in the volume of semen, either due to there's something wrong with the seminal vesicles or ejaculatory duct, or there's some ejaculatory dysfunction. And I think Mr. Murali will talk more on this. So the patient comes to you, please examine the patient. Okay. So far, when it comes to my clinic, the patient comes together with the wife. But I don't know why minta Dr. Hatta examine. I mean, we got so many female gynecologists kan, boleh lah examine sekali kan, atau examine lah. Kalau tapi patient so far tak ada yang minta, saya nak male saja doktor. Sekejap dia. Okay. Look for palpate. Look for vas difference whether it's absent or not. If the patient is azoospermic, then you get history that he says that his urine is a bit turbid. He may have retrograde ejaculation. That means the semen doesn't go forward, it goes back into the bladder. So get the urine FE for examination, urine for examination, and look for spermatozoa inside there. It can happen in patient with failure of bladder neck closure problem, or sometimes patient with have history of operation. There are treatment, oral anti-alpha agonists that may help in retrograde ejaculation, but I think Mr. Toady will talk more on this. And you must also understand that patient with diabetes may have erectile dysfunction problem and may also suffer from failure of emission. I had one patient last 2 months ago where they were been trying for the past 6 years. When I tried to examine the wife and putting a vaginal scan probe, she was painful, but when I did the vaginal examination, I found that the hymen is still intact. Six years of marriage. Then baru nak ambil history laki dia kan. Oh, masalah. Should have taken the history earlier. We found that the husband is diabetes on injection and he has erectile dysfunction. but it never come and seek treatment. So how can you put your penis inside your wife's vagina in that case? So we found out later that he has to be referred. I refer him to the urologist as well as the endocrinologist to sort out his problem. Absence of vas difference can be associated with cystic fibrosis, but again, like I said, it's not very common here in Asian countries. Right? If you have ejaculatory problems like obstruction, there is a 25% chance it can be associated with cystic fibrosis. So if you have this problem, it's advisable for you to do genetic testing. This is the ejaculatory ducts. Okay, physical examination. Look at the patient as a whole. Any excessive testosterone like virilization, sometimes they take hormones prescribed by their doctor, especially our general practitioner colleagues. We have actually many patients yang our FMS ataupun our GP colleagues somehow prescribe them testosterone for azoospermia. Please don't. You will cause negative feedback inhibition. You make the azoospermia worse. Examine the scrotum. Look at the size. I've been asked by junior doctors, what is the normal size? If it's the person who asked me is a guy, I said you go check yourself. But we have ways to look at the actual size. We use this thing called the Prada, orchidometer, which is this thing. So sometimes this thing get lost in my clinic because they want to see whether they have normal size or not. But anyway, a normal size is 15. Anything above 15 to 25 is the normal size. So you palpate this and you compare with the patient. Sometimes you have a patient with this small size. There's something wrong with the production from the start. Okay, you can get this from eBay. It's about $100 US. It's expensive. And then you palpate also for the vas difference I mentioned. Abdomen examination is important because you have to look for any scarring, especially if you had a history of inguinal hernia operation before, especially kalau dia tak mesh. What about patient with normal sperm volume, azoospermia? Usually they also have normal testicular volume. You look at the blood test. Take FSH-LH. If the FSH-LH of the male patient is normal, most probably he may have obstructive cause of azoospermia. That means there's some obstruction in the vas deferens or cyclic duct. So generally you don't need to do a testicular biopsy. If the FSH-LH is low, he may have pre-testicular azoospermia. That means there's a hypogonadotropin, hypo. Treatment can be given by supplementation of FSH injection. I will explain to you more later. If he has elevated FSH-LH and you check the testis is small, both sides, he had an insult prior to akil balik, prior to puberty. So this patient unfortunately will also have azoospermia and is of the non-obstructive type, meaning the production of the sperm is low from the start. This kind of patient may have associated stolicell or immature arrest, or may be totally inability to produce sperm at all. Right? Okay. So low FSH-LH, pre-testicular, normal FSH-LH, either obstructive or non-obstructive. I will probably do a PISA. Aspirate the sperm. Try to aspirate sperm from the epididymis. If it's none, then most probably he has non-obstructive, and then we go to testicular biopsy. If this is FSH-LH is high and small testis, usually it's testicular failure. Nothing much can be done. In men with I'll skip this because Mr. Morali will cover that. When do you do genetic investigation for azoospermic men? All men with hypogonadotrophic hypogonadism referred to for genetic counseling. Almost all of them will have some sort of congenital abnormalities in the hypothalamus, and there's some genetic alteration. So this kind of patient, send them for genetic testing. If men with absence of vas difference or obstruction of the epidermal duct, they also carry a 25% chance of cystic fibrosis. They are also they can be considered to be sent for genetic investigation. And if all you examine the patient, very high FSH LH, low small volume testis, they may be associated with karyotype of Y microdeletion or Kalman or Klinefelter's. So this kind of men are better sent for genetic testing to look at the karyotype. So how do you manage men with azoospermia? In hypo or pre-testicular, we have tried given FSH, LH or gonadotrophin releasing hormones analogs to stimulate the spermatogenesis. More than 90% of the time, spermatogenesis is induced and the man can have back his sperm. However, therapy may take more than 6 months. My own practice in my clinic, I'll give them FSH injection with ACG injection for 6 months. First 4 months, then we try to do the sperm analysis again to see whether there's any sperm. If there's none, we can extend to up to 6 months and to see whether repeat the sperm analysis to see whether there's any sperm. Most of the time they have, but there are not many cases with this actually. Most of our cases are those of the testicular one. Reproductive ejaculation, pseudoepiandry, but I think Mr. Morali will talk more on this. Obstructive azoospermia, there are a few options. This is what we do in the fertility unit. Sperm retrieval, surgical sperm retrieval, either TESA, actually we start off with PESA, percutaneous epidermal sperm aspiration, where we stick a needle into the epidermis and try to suck it out. If there's any, then we will freeze the sperm and look and use it later for ICSI or EC. If we don't find any sperm with this, we go to the next step, which is the TESA, TESA. Kalau ini pun tak dapat, and then we open up the testis and we take a biopsy, send it to lab and see whether we can find any spermatozoa from there. If we do, we will freeze them and use for EC. So this is a procedure that we do in the lab. Actually, this is when I was in UKM, we scrub macam ni kan. Tapi sekarang ni tak payah scrub, buat kat klinik kan. Where we put in the needle and suck out. So patient must be counseled. This procedure has its risk, very uncommon. Formation of blood clot is one of them. So when you get the consent, must make sure that you explain to them the risk. But this is quite a simple procedure and usually less than 5 minutes. Kalau tak dapat to that, then we have to open up the testis and take out the for biopsy. Alright. There are certain operations that can be done to bypass. We have had patient who has history of vasectomy done. So they ask us, boleh ke you reverse? That one I think you better ask the urologist later lah. Tapi usually with the kind of patient, nak senang bagi kami akan buat PESA terus. Dia baru kahwin isteri nombor 2 contohnya, umur dah 60, tapi masih lagi nak mengandung ke anak dia. So either we usually do a PESA. Right. For non-obstructive azoospermia, a testicular sperm extraction or TSE is done, studies have been shown that it's as successful as 75% we can retrieve the sperm. Okay, what do we do? It's best if it can be done under microscope. That's what MESA means, M-TESA. And you look for the spaghetti, the Maggi. You look for the spaghetti, the larger tubules. You can get sperm. In patient with failure to ejaculate, I just mentioned, nanti akan di-mention urologist. Because quite interestingly, we have had patients like this, and as you know, like our hospital do not have a urologist. It's very far. They are very far away in Queen 1. So sometimes we have to do our own treatment. We don't have this machine. This machine is where we put in between the penis and it start vibrating. That's what we call vibro-stimulation, with the hope that it will ejaculate. But I've had friends who tried to do this, but not with electricity, electro ejaculation. This is why they massage the prostate, and you can ejaculate afterward. So we do manual massaging. Memang meletihkan. Masuk your finger into the anus and then try to massage there. I wonder you can get, massage yang ada music, but this we tried once lah, tak jadi. After 1 hour I gave up. Okay, susah nak ejaculate orang ni. Which azoospermia might need the biopsy? Again, those with non-obstructive azoospermia, they may benefit, but this patient kita buat bukan sekadar diagnosis saja. Lepas kalau kita dapat sperm tu, we have to freeze it or use it later for EC. Okay, let's skip this. Is there any role for hormone therapy for men with azoospermia? It's controversial. Like I said, maybe for hypo, but the rest are controversial. I have had colleagues who tried to give clomid. I tell you now, it doesn't work for azoospermia. I don't know why you give clomid, because you give clomid to the wife, you give clomid to the husband. It doesn't make sense, because it's an anti-estrogen kan. Paling kurang pun clomid cost what does anti-estrogen cost to the guy? Jadi abang sadar, is it? Because no estrogen, more testosterone, doesn't cost anything, right? But people have tried HCG injection, because it says that HCG may increase the FSH by a negative feedback mechanism. But then again, if you have that, why don't you just give FSH? People actually have also tried giving HCG, like I said, HCG 3 times a week. Again, it may not work. We have tried many things. So sometimes this kind of patient, if we were in the Western countries last time, this is where we advocate them to go for sperm donors. But not all patients will agree to that. So precisely, there's no recommendation of any one treatment is better than the other in non-obstructive azoospermia. Again, I must say, androgen is contraindicated in azoospermia. So please stop giving testocaps to patients with azoospermia. Nothing to do with formation. Nanti you make it worse actually. And this is my last slide. Like I said, what are the options with this kind of patient? Either you go for sperm donation. In Malaysia, there's no law to govern sperm donation, but in the Ministry of Health, we do not do it due to ethical as well as religious reasons. So what are the other options? Scientists in China has been trying or playing with using artificial sperm from the immature germ cells from the patient. From the stem cells of the patient. So withdraw stem cells from the patient, try to harvest it in the lab to form spermatozoa. And this report from China did say that in animal studies they have managed to form these embryos. So whether it work in male, in human, we still don't know. So, sorry. So like I said, what are the options for patients with azoospermia? If it's hypo, they have a good chance by giving FSH. If it's obstructive, they can be subjected to sperm SSR, surgical sperm retrieval. If it's not obstructive, most of the time they have to undergo, of course, they have to undergo testicular biopsy. If it's of Toady cell syndrome or mature arrest, maturation arrest, or failure of spermatogenesis, most of the time this patient have no other options except for either adoption or donor sperm. Okay, and this is something new we have to think about in the future maybe. With that, I thank you.